The next speaker is Mr. Arthur Cummings. The talk is about Contoura profile, why and how.
Thank you very much. Thank you for the kind invitation, and Tiago, thank you for your welcome to Oporto. It's a beautiful city, and for showing me Brazil Avenue. I've got a very nice idea of your city and the beautiful weather. I'm going to speak about Contoura, how and why, and Tiago also asked me just to speak about laser in general, perhaps. So it's actually very appropriate that today, this month, March, is the 30-year anniversary of PRK. So the first sighted eye was treated 30 years ago in Tulane University in New Orleans by Marguerite MacDonald, and now her husband, Stephen Kleiss, he was the PhD scientific observer on this study, but it's 30 years ago. And then, thanks to Birato and Pellicaris, LASIK was performed and people thought about doing the ablation under the flap. And the very first profiles that were used were Mandelin formula-based. So what they did is they corrected the vision and improved the uncorrected acuity, but at the same time they introduced higher order aberrations and caused glare and halos. So in 1999, Wavelight were the first company to think about the reasons for why people were inducing aberrations. And what they noticed was that when you had a mirror that was directing a flying spot to the cornea, if the flying spot was directed perpendicularly onto the cornea, it had the effect that you expected. But when the mirror deflected the spot towards the periphery, then you had lower fluence because of the less energy sun was being reflected and also the larger footprint, and so you got reduced efficacy. So all a wavefront optimized profile is a mathematical calculation to compensate for the shots that are lost. So people realized that wavefront optimized was a much better solution than a standard treatment, but they also noticed that they weren't correcting pre-existing aberrations. So wavefront guided treatment started in around about 2001. I did my first cases, and Theo Seiler had already done 22 cases in a pilot study that showed that this was working very well. We used churning aberrometry, and I then proceeded to treat the next 250 eyes that I did, all wavefront guided. So with a wavefront guided ablation, you're using the entire eye's optics to design the ablation profile, and it's designed primarily to improve the uncorrected acuity and the refraction, obviously, but also to reduce higher order errors. And so the principle that was used was that of the churning aberroscope. So that input going into the eye was 1 square centimeter in size, and it's projected onto the back of the eye, onto the macula, and then a pinhole camera would image the macula and then look at the difference between the two images, and from that would generate a treatment profile. So one of the things to consider, this is an eye trace image, and one of the things to consider is once a patient starts seeing poorly, this is the entire eye, and the E starts degrading. Many times the cornea is still perfect, but the noise is coming from inside the eye. So it's important to remember with a wavefront guided procedure, if there's any noise inside the eye, you're going to transfer that to the cornea to correct the problem for now. But later on, when people have cataract surgery, then you have an aberrated cornea. So on occasion, we couldn't validate wavefront maps, so wavefront wasn't possible. So we needed corneal data to drive laser treatments. And in the meantime, Theo Seiler and Michael Moroccan were one step ahead and already thought about this. So the first procedures we did topography guided using Placido disc were in 2004, and 1 year later we started doing procedures based on the Scheimpflug. And so we heard a great talk just a moment ago about TCAT for complicated eyes. So we know the cornea is the most important optical interface in the eye. It has the greatest refractive power. It can be treated with data derived from either the oculizer or the topolizer, and historically it's been used to treat eyes that have problems. And these problems are mostly around regularization of the corneal surface, and as we heard a moment ago, the refractive outcome is a secondary issue. So if we did a wavefront map, one of the beauties of the churning system was you could see the data on the back of the eye and you could validate the data. You would never use data like this, but when you capture data like this where you could see the points were all captured and the software was giving it the green light, then you know you have good data and you can go ahead and do a wavefront. But many times you couldn't. So this is just one example of a patient who had a previous treatment, had a small optical zone, especially in the vertical meridian. And if you look at the profile down here, you can see why this patient's got complaints of vision. And then following a topography-guided procedure, you have a much larger optical zone, and you can see a much better profile, nice and prolate and large and symmetrical. So we had a paper published maybe 8 years ago, looking at the outcomes comparing topography-guided procedures based on oculizer versus those based on topalizer, and we could find no difference. So both gave equally good results. Another ablation profile is called custom Q, which is asphericity guided, and you can target a certain asphericity. You never get it, but at least you're targeting it, you're going in that direction. And with custom Q, you can either induce spherical aberration if you're trying to do advanced monovision and increase depth of focus on the reading eye, or you can reduce spherical aberration when you don't have decent wavefront maps. And topography-guided treatments, every time you do them, you were given the option of putting in a target Q value. So with any normal myopic treatment, including on wavefront optimized, the more myopia you treat, the more spherical aberration you induce. It's just a function of what you're doing. But what happens with custom Q, and this slide is courtesy of Theo Seiler, is up to -6. For a given amount of myopic correction, you're inducing less spherical aberration. So what it does is it keeps the prolatus of the cornea, specifically within the optical zone, obviously, and under all lighting conditions. So if you think of how good wavefront optimized outcomes are, the question is, why even bother with all these customized treatments for a primary outcome? So I'm going to quickly show you the results of the most recent multi-center study looking at wavefront optimized LASIK. And this study did something different. It looked at what the uncorrected binocular vision was at 1 month post-operatively compared to the preoperative best corrected acuity. And this study showed clearly that the vision post-operatively was significantly better than the best corrected acuity preoperatively. And if you look at the level of uncorrected acuity, 90% achieving 20/20, 60% gaining 1 or more lines. Now this we don't see all the time looking at retrospective data, but in clinical prospective trials, it's the kind of results you see. You can see a very high R-squared, so very predictable. And you'll also see that 93% of patients within a half diopter. So these patients didn't have much astigmatism to start off with, but post-operatively, every single patient had a quarter or less diopters of astigmatism, and then also a very good stable outcome through 6 months. And looking at contrast, there was actually an improved contrast sensitivity with an optimized profile for a correctly chosen patient. So when you have a profile that is so good, it's very difficult to find things that are going to be significantly better. They're going to be improvements, but to find something significantly better is going to be a big challenge. So why do you even consider Contoura vision? So I think the first thing I just need to do is speak about Contoura for a second. So Contoura, by definition, is a LASIK procedure using the topalizer on a primary procedure, not a secondary procedure, and only for myopia. So the first reason you consider Contoura is it gives you a bigger range of treatments you're doing, so you're not treating everyone exactly the same. The second thing is if you follow the FDA guidelines, you're going to get very good results. I'll show them in a second. And the other reason is, I hope it's not a big problem in your area. It doesn't sound like it. But in many areas, people market other technologies very aggressively. And one thing that's nice about Contoura is that as a name that patients understand, they sort of get what you mean when you speak about Contoura. So you can really promote LASIK again in a very positive way. So how is Contoura different to wavefront optimized? Well, the first thing is Contoura vision, the ablation profile is affected by the K values, unlike optimized, and it's also influenced by the Q value. And then the cylinder and sphere are treated simultaneously, which is not the case with optimized, and then it uses the corneal higher order aberrations in addition to the refractive data to do the treatment. So we had a great talk a moment ago of how TCAT's been used since 2004 for complex eyes. Then when Alcon went to the FDA a few years ago saying we want to register topography-guided treatments for difficult eyes, the FDA said no, we're not going to approve for difficult eyes. You must first do a study on primary eyes. And so this is where Contoura came from. The name wasn't born at that stage, but that's where Contoura comes from. And then I want to just share with you some experience of what Contoura looks like in the real world on primary eyes. So this is what we would have followed over all the years. If we have a patient with no problems and all we want to do is improve the vision, we would do wavefront optimized. If we wanted to induce or reduce spherical aberration, we would do custom Q. If the patient had problems with topography or mesopic visual symptoms, or they couldn't correct to 20/20, then we would do a wavefront. If the wavefront maps were valid, we would do wavefront guided. If they were not valid, we would do topography guided. So that's TCAT. With Contoura, it's different. Now Contoura goes into the front of the line. So this is a patient with a previous treatment, as you can see. And if this patient was sitting in front of me, I'd say, all right, if we do a treatment for you now, here's your topography. And if we do an optimized treatment or give you spectacles or contact lenses, we're going to correct the spherical element and we're going to correct the astigmatism, but that's all. But if we include the higher order aberrations, we're also going to correct the coma, and we're also going to correct the remaining higher order aberrations, which in this case is corneal trefoil. So we've actually seen this before. It was unpredictable, typically two-step procedure. First step, regularize the cornea, then the refractive correction 6 months later with optimized. What we did, because we've been doing this since 2004, is we started making predictions with the first treatment of what the refractive effect would be. And once we started finding we were quite accurate, we started combining them into one procedure. And we now have the same outcomes as we do with optimized in terms of predictability. This is courtesy of my friend, Professor Ahmad Asaf, who's got a very nice example of how Fourier analysis and topo guided is more understandable. So here you see the Fourier analysis of the topography, the corneal astigmatism, the decentration or coma, and the higher order aberrations, the irregularities. And if you now go and look at the higher order ablation profile, so this ablation profile is the ablation profile when there is no refractive correction, then you can see how beautifully the higher order aberration treatment is correcting the coma. And the moment you add the cylinder and the refraction, you can now see that even though this is irregular, obviously, because it's correcting those other issues, it now matches the cylinder a whole lot better. So for almost all areas you'll ever treat, the lower orders are still going to dominate the higher orders. But you can see how this treatment is including both. So this is what the FDA study showed. First-time treatments. First time it was presented using the term Contoura was in Barcelona in 2015. This was an excellent study, like a typical FDA study with very good experienced centers across the country. There were 3 key endpoints: safety, effectiveness, and no retreatments were performed in the study. There were 250 eyes, of which all of them made it to final enrollment except one. It was up to minus 9 sphere equivalent and up to 6 diopters of astigmatism. The refractive outcomes were excellent and stable over time in terms of cylinder and sphere. And now you see that at 12 months, 94% of patients were within half a diopter and 99.6% within 1 diopter. If you look at the cumulative vision, where we typically with optimized are getting somewhere around about 90%, we're now looking at higher numbers achieving 20/20. But what was different about this outcome was the number of patients getting 20/16 and the number of patients getting 20/12. It's very uncommon to see those kinds of numbers getting 20/12 with optimized. This is a safety profile, and you'll see almost no eyes losing lines with a great number of eyes gaining lines. And if you look at the efficacy profile, so this is pre-op best corrected versus post-op uncorrected, it looks like a safety profile. So still many more eyes gaining lines than losing lines. All of these marked in green had statistical significance in terms of their improvement. So light sensitivity, driving at night problems, reading difficulty. And 98% of patients said that they would do it again. And there was statistical significance was achieved for light sensitivity, difficulty driving at night, reading difficulty, and glare with TCAT LASIK. And TCAT produced a 2 to 3-fold higher number of eyes with clinically significant increases in contrast rather than decreases. So my interpretation of this study was that these eyes were actually normal preoperatively, and they were specifically selected to have very complementary topographic and refractive findings. So these weren't complicated eyes. This would be the single most difficult group to show an improvement in, yet Contoura did show an improvement in it. But it's a small improvement, but it's an improvement. And the manifest refraction was used. So in the real world, from a patient's perspective, as I showed you earlier, on a primary eye, we'd show the patient, this is what a regular treatment would do for you. And if we're going to do Contoura, we're going to take into account the higher order aberrations that you may have too. And I haven't met the patient yet who says, yeah, I wouldn't like to fix that if you can. It makes sense. In our own findings, in terms of predictability, what we've seen, looking retrospectively at our data, is what's giving us our highest correction for the moment is custom Q is basically at 1, at 9, because we can enter a refraction there to 100ths, the same as you can with Contoura, but with Contoura we also have the additional issue of the higher order aberrations. But nevertheless, an R squared of 1.02 means you're very, very accurate. In fact, we're more accurate with Contoura than we are with wavefront optimized. This is something that's really interesting from my own data, looking at the results over time and through a 6 months follow-up, or I think this is, the visit 6 is 12 months. In fact, you can see that Contoura is giving a more stable result. And I think the main reason is because it's taking the cornea into account so much, it gives a very good blend between the optical zone and the transition zone into the untreated cornea. So the way we do it is using the manifest refraction. You need to find cases that have a good correlation between the manifest axis and cylinder on topography and refraction. And then once you key in the higher order ablation profile, it needs to be less than 7 to 10 microns. So here's a typical cornea. You key the data into the laser, and once you key the data into the laser, you enter a 0 refraction. So you're only looking at the higher order ablation. You can see this is correcting trefoil, and the highest amount of ablation here is 8 microns. And the moment this higher order ablation profile map is less than 10 microns, you can go ahead and simply do the treatment on a manifest refraction. And you should get the same results as the FDA, which were outstanding results. So today in my practice, I'm doing 50% of cases Contoura vision. I would do more, but we only do it when we have data that's really validated and reproducible. Custom Q we're using 40% of the time, optimized 8% of the time, and wavefront guided 2% of the time. And I think my final comment, because this is my last slide, is one thing we need to bear in mind with all the modern lasers, optimized profile or the aberration-free profiles are such good profiles that when you're thinking of doing a customized treatment, if you don't have data that's valid, there's nothing wrong with reverting back to the standard treatment. So thank you very much for your attention. I appreciate it. Thank you.